Hi, my name is Peta Tauchmann and I'm a nurse practitioner and credentialed diabetes educator working in Brisbane. Welcome to this web-based learning session about gestational diabetes mellitus. In this video, we will consider what is gestational diabetes and who is at risk, how we diagnose gestational diabetes, common questions that I'm asked by mothers-to-be in my clinics. We'll look at the treatment and management, and finally, postpartum monitoring for gestational diabetes. So what is gestational diabetes? We define it as a carbohydrate intolerance of varying severity that appears during pregnancy. During pregnancy, the healthy woman produces hormones that allow the baby to develop. These placental hormones include cortisol, estradiol, and human placental lactogen. These hormones naturally induce hyperglycemia, but this is usually offset by an increase in insulin production in the pancreas. In gestational diabetes, sometimes the mother's body is unable to cope with the insulin resistance that these hormones cause. When this occurs, the blood glucose levels increase, and we call this gestational diabetes mellitus. Gestational diabetes is related to type 2 diabetes, but it's not the same thing. The main problem is insulin resistance. And up to 40% of women can develop type 2 diabetes later in life. The baby has an increased risk of obesity and type 2 diabetes. And we think of gestational diabetes as the most common complication of pregnancy. Those at greatest risk are women from some ethnic groups, including Asian, from the Indian subcontinent, Aboriginal or Torres Strait Islander, Pacific Islander, Maori, Middle Eastern and African nations. Women who have a body mass index of greater than 25 kilograms per square metre. Those with higher risk factors are those women who have a history of gestational diabetes, elevated blood glucose levels, or they've had a large baby in the past, a baby larger than 4,500 grams or 9 pounds. Women with a body mass index of greater than 35 kilograms per metre squared, with polycystic ovarian syndrome and certain medications, including glucocorticoids and antipsychotics. Next, I'd like to talk about the diagnosis of gestational diabetes. During pregnancy, women are routinely screened via a glucose tolerance test at 24 to 28 weeks gestation. We do it at this time because this is when the placenta starts to produce large amounts of diabetogenic hormones. Those with higher risk factors for GDM may be screened earlier, and if the result is negative, we recommend screening to be repeated at 24 to 28 weeks gestation. The oral glucose tolerance test is the gold standard test for gestational diabetes. This requires the woman to have a 75-gram glucose load orally over 2 hours. We ask women to fast before the test. A glucose level is taken in the fasting state, and if it's greater than 5.1 millimole per litre, then it's above target range. At 1 hour, it should be less than 10 millimole per litre, and at 2 hours, it should be less than 8.5 millimoles per litre. If any one of those targets is exceeded, then that qualifies for a diagnosis of gestational diabetes. These levels were introduced following the HARPO study, which was a global study. HARPO stands for the Hyperglycemia and Adverse Pregnancy Outcomes Study, and this was published in 2008 in the New England Journal of Medicine. This demonstrated a reduction in adverse pregnancy outcomes using the targets that I've shown you. Let's talk about some common questions that I'm asked by mothers-to-be when they visit me in my clinics for gestational diabetes consultations. Women commonly ask me if the baby will be born with diabetes, and I'm happy to tell them that this is unlikely, although there is some risk to the child of obesity and type 2 diabetes later in life. I've also been asked what the risks of gestational diabetes are for the mother and for the baby. And if the blood glucose level is controlled, the main risk is really weight gain. The extra insulin production that can occur with hyperglycemia causes what we call macrosomia, or large babies, and this can complicate delivery for mother and baby. So we try to avoid this. The next question I'm commonly asked is, my blood glucose level was just a little bit too high. Does that mean it's less important? And in fact, I like to tell women that the glucose tolerance test is a predictor of potential problems, not actual problems. And by noting the elevation in blood glucose levels, we can work to reduce risk factors and promote a healthy pregnancy. Other women have asked me how common gestational diabetes is. And it translates into around 5 to 8% of all pregnancies. And most commonly, insulin resistance disappears when the baby is delivered. Now, let's take a dive into the treatment and management of gestational diabetes. And primarily, this is lifestyle focused. We want women to focus on healthy eating and weight management. A weight gain of 7 to 18 kilograms is considered acceptable depending on the weight of the mother at the time of gestation. We recommend low glycemic index food, which comprise 40 to 50% of the energy intake from high fibre carbohydrates. 20% of energy should come from protein and 30 to 40% of energy from unsaturated fats. We don't recommend calorie restriction because this can cause birth defects and it really isn't recommended. If you have a woman in your clinic who is thinking about restricting their calories because they've heard that carbohydrates are bad for them, recommend that they see a dietitian. Exercise is another really important lifestyle component, and we recommend 150 minutes of moderate activity in a week or 10,000 steps a day. The studies tell us that women who maintain a healthy level of activity during pregnancy reduce their risk of gestational diabetes by 56%, and the risk of diabetes long-term is also reduced. Exercises like walking, swimming or aqua aerobics, cycling, any muscle strengthening exercise, yoga, Pilates or pelvic floor exercises are great for pregnant women, but we do recommend that we avoid contact sports, hot yoga and high impact exercise. Some women may need medication in 10 to 25% of women, and metformin is commonly used by obstetricians in Australia. It is listed by the Therapeutic Goods Administration as Category B3. What this means is that there are no robust studies for the use of metformin in pregnancy, but there are also no serious recorded adverse outcomes, so it's considered to be safe to use. Some women will need insulin therapy, and where insulin is required, we always use analogue insulins. A starting dose of 0.8 to 1 unit per kilogram is recommended, depending on the weight of the woman. We find that glucose levels can often increase at the very end of the pregnancy, and sometimes medication is only needed for a couple of weeks. If it's prescribed, it's required, so we recommend that women have it. Blood glucose monitoring is another vital factor for monitoring glycemia during pregnancy. The first changes in blood glucose levels will be seen in capillary blood glucose. Women are recommended to monitor up to 4 times per day, a fasting level first thing in the morning, and 2 hours after each meal. The glycated haemoglobin is not recommended, as hematocrit changes during the 2nd and 3rd trimester will interfere with the result. We know that changes in hematocrit indicate a change in red blood cell turnover, and this affects the accuracy of the glycated haemoglobin. For blood glucose monitoring, we want to recommend the targets that are in the guideline laid out by the Australian Diabetes in Pregnancy Society. Fasting blood glucose levels and before eating are recommended to be less than 5.3 millimoles per litre, and 2 hours post-meal we recommend that they're less than 6.7 millimoles per litre. Some obstetricians will also recommend a 1 hour post-meal reading, and that should be less than 7.8 millimoles per litre. Guidelines are great, but targets are always individualised, and they may be higher depending on the needs of the mother. Most importantly, we want to prevent hypoglycemia, and this is the main thing that we're going to take into account when recommending blood glucose targets. After the baby's delivered, it's really important that we check that the mother doesn't still have diabetes. There's a 50 to 70% risk of type 2 diabetes 15 to 20 years after gestational diabetes. But the initial follow-up with a glucose tolerance test needs to be 6 to 12 weeks post-delivery. And I tell mums that this is about the time of baby's first vaccination. After this, the blood glucose level should be checked every 1 to 2 years via a routine fasting plasma glucose or by HbA1c. I hope you've enjoyed learning about gestational diabetes. If you'd like to learn more about diabetes, I recommend the website of Diabetes Australia and the National Diabetes Services Scheme, which have gestational diabetes resources. For specific guidelines on gestational diabetes, it's worth visiting the website of the Australasian Diabetes in Pregnancy Society at www.adips.org. and also the website of the International Association of Diabetes and Pregnancy Study Groups.
My Health PD, more than just CPD.